you would describe this as a complete transverse fracture of both the metaphysis of both the radius and ulna, with dorsal displacement of the distal fracture segment. So this is actually fall on an outstretched hand, and it has a fork deformity. So it also has a proper name, and this is called Colles fracture. So Colles fracture, and the opposite of Colles is Smith's fracture. So for Colles, it's a dorsal displacement. For Smith's, it's a volar displacement. Remember your anatomy. So dorsum of the hand, your anatomic position. So yun yung basis natin. For dorsal displacement and for volar displacement. So here are the different types of fractures involving the wrist, and the most common of these are Colles and Smiths. Okay, there are also named fractures of the pelvis. Basically, what's important here is just that you should be able to differentiate between the stable fractures and the unstable fractures. At your level, you don't have to know the names of all these types of fractures. You just have to know that that because the pelvis is a ring. So if there is disruption of that ring, then you have a unstable fracture. If the ring is not disrupted, like in this particular case, it's just an avulsion fracture of the ischium, avulsion fracture of the iliac ring. That is a stable fracture. But when rings get fractured, they tend to get fractured in two places. So, eto na yung mga unstable fractures. So here we have fracture involving the sacroiliac joint and the pubis, and so on and so forth. So it's usually, and the worst one is the open book fracture, wherein you have fractures on both your fracture dislocations on both your sacroiliac joints and fracture dislocations of the pubic bones. So again, just at your level, just differentiate between stable and unstable fractures. Femoral neck, these are also named, well, not really named, but there are different types of fractures, so you don't just, it's just a fracture of the femoral neck. You have to be, the localization is more toxic, so you localize it as subcapital, transcervical, intertrochanteric, subtrochanteric, or just the greater trochanter, or just the lesser trochanter. Okay, ito must know. Sauter Harris and board exam question. So, mnemonic here is Salter, S-A-L-T-R. So, type 1 is slip. It's a fracture of the epiphysis, fracture of the growth plate. Type 2 is above. So, there is shearing that splits the growth plate, and then there is also involvement of a part of the metaphysis. So growth plate and metaphysis. So, above, whereas yung sa type 3, that's lower. So it's distal to the metaphysis. So it's you have an epiphyseal fragment. So this is type 3. So S, slip, above, lower. Type 4 is together, both metaphysis and epiphysis. And type 5 is a compression fracture, ruined. So S-A-L-T-R. So that's the basic mnemonic for Salter Harris fractures. So here, anong type of fracture to? No, it's type 2. You have a slip fracture, but you also have another fracture involving the metaphysis. Ito, this is slip, and you also have a fracture segment here. So it's actually the same type. It's also a it's also a type 2 fracture. It's also above. Take note na iba lang yung orientation because this is the foot, and this is the leg, and this is the wrist. But we're still talking about type 2 fractures for both of these. Okay, so that's it for fractures. Now we're going to talk about bone tumors. In bone tumors, especially at your level, I don't expect you to be able to say whether that's an osteosarcoma. I don't expect you to give me the histological diagnosis of your tumor based on the X-ray. I mean, when you are more experienced as a radiologist, you can. But in general, you don't have to. It's better if you can, but you don't have to. What you have to be able to do is you have to be able to say whether the lesion you are looking at is aggressive or non-aggressive. Note that I'm not using the term benign or malignant because the problem with bone tumors and the problem with osteomyelitis is osteomyelitis can mimic bone tumors, and osteomyelitis can, especially acute osteomyelitis, it always has an aggressive appearance. And some forms of metabolic bone disease have an aggressive appearance also. So, but the take-home message here is, at the very least, you should be able to determine the characteristics which can determine whether your lesion is aggressive or non-aggressive. So how do we describe our bony tumors? Okay, in which bone is the lesion located? Siyempre, fibula, tibia. But in which part of the bone is it located? So here, it's not enough for us to say proximal medial distal. We have to say whether it's metaphysis, epiphysis, diaphysis, metadiaphysis, because there are some lesions which will respect the epiphyseal plate. There are some lesions which will grow past the epiphyseal plate. Is it central or is it eccentric? Because some lesions tend to be central, some lesions grow on the side, they're eccentric. So how large is the lesion? Are many bones involved? If there are many bones involved, it's most likely metastatic or infectious. It's not going to be a primary tumor. And what is the tumor doing to the bone? Are there lytic changes? Are there plastic changes? What is the bone doing to the tumor? What are the reactions of the bone? I will be showing the reactive changes here, and some of these reactive changes are benign, and some of these indicate malignancy. Is there a cortical break? Is there a soft tissue mass? Because if there's a soft tissue mass, that's a higher probability for malignancy. Whereas cortical break, yes, you can see it in both aggressive and non-aggressive lesions depending on the extent of the lesion. And the matrix will also, what is the matrix? That will help you determine whether you are looking at an osteoid lesion like osteosarcoma or a chondroid lesion like chondrosarcoma. So what does the lesion do to the bone? Here we have a geographic sclerotic rim and another one, a rim with white transition. So this one is a moth-eaten appearance and this is a permeative appearance. Among these, which ones are indicative of non-aggressive lesions and which ones are indicative of aggressive lesions? Ito. Non-aggressive because sclerotic ring well defined, the bone has time to react to your lesion and form a ring around it. Whereas moth-eaten and permeative, these involve the bone so fast that the bone cannot react. So ito, if you see this, that's a good sign. If you see this, that's a bad sign. That's already a sign of aggressiveness. And then the periosteal reactions. Of all of these, this is easier to memorize because only buttressing is a non-aggressive periosteal reaction. The rest, Cadman's triangle, sunburst, hair on end, and lamination, these are aggressive reactions. These are aggressive periosteal reactions. So when you see this, think of an aggressive osseation. The age of the patient is also important because different patients will present with different types of, and patients of different ages will have different tumors which are more common. And like I was saying a while ago, the location is also important. Is it in the metaphysis? Is it in the epiphysis? Does it cross the epiphyseal line? I was talking about whether the lesion is eccentric or central. So an aneurysmal bone cyst is an example of an eccentric lesion. Based on this appearance alone, anong call nyo? Aggressive, non-aggressive? It's actually non-aggressive. If you look at the borders, it's smooth. It has smooth sclerotic borders. So this is a non-aggressive. It's a non-aggressive lesion. However, it can be so severe that it can cause fractures din. Okay, this is an osteochondroma with growth away from the bone. Aggressive, non-aggressive? Also non-aggressive. Smooth geographic borders, and it's just confined to that. Aggressive, non-aggressive? Aggressive. You will already see that there is bone destruction, and you can see aggressive periosteal reactions. You can see that you already have a Codman's triangle here. You have a soft tissue mass already, and this is what we call an osteoid matrix. So the question, what is the matrix, refers to this. You will see a matrix here. So that's already indicative for osteosarcoma. Again, ito, osteosarcoma, it's also aggressive. You will see your Codman's triangle here also. Chondrosarcoma, looking at it here, at first glance, you would say non-aggressive. And you would probably say non-aggressive, but that's the problem sometimes with chondrosarcoma. This type of matrix is what we call a chondroid matrix. It's a stippled appearance, not like your osteosarc, which has a cloud-like appearance. Of course, one of the things I was talking about is multiplicity. So if you see multiple well-defined lytic lesions scattered in the skull, you would think metastasis versus multiple myeloma. Another thing is bone metastasis. Now, bone metastasis, it can have many different appearances. Soft tissue masses, it can be sclerotic, meaning it's dark, meaning it's white, or it can be plastic with soft tissue masses. Sometimes the problem here is, actually, you don't have to memorize this again. My take-home message for this is sometimes it's difficult to differentiate between compression, especially in older women with osteoporosis. It's difficult to differentiate whether your compression fracture is due to osteoporosis or whether it's due to metastatic or whether it's due to bone metastasis. Take-home message here is the modality of choice is MRI. That's it. Take-home message. If you're in doubt, have an MRI done. And this table gives the differences between the two. I'll just give examples of yung mga so we've talked about trauma and tumors. Now we're going to talk about arthritis. Most common is degenerative joint disease. And the hallmark of DJD is joint space narrowing. It's the most important. This is the most important characteristic. You look for narrowing of the joint space. You can see subcondylar sclerosis of the opposing joints, and you can see osteophyte formation. So in this part, there is joint space narrowing, you will see osteophyte formation and subchondral sclerosis. So, looking at the X-ray of the hands, you can see multiple examples of joint space narrowing with subchondral sclerosis in the distal and proximal interphalangeal joints. Sacroiliac joint, again example, subchondral sclerosis with joint space narrowing. Sometimes you can see subchondral cysts, but at interlevel kind of hard to differentiate. Now, for joint disease, particularly involving the knees and the hips, we have a grading system. So, it's called the Kelvin-Lawrence grading system, and we use that to determine how severe the joint space narrowing is. Okay, so we've talked about degenerative joint disease. Now, just a brief review of rheumatoid arthritis. For rheumatoid arthritis, these are the clinical characteristics. If you remember your patho, dopamine rush, yun. So, just review that. But for the X-rays, basically the hallmark is regional or periarticular osteoporosis, particularly in very early rheumatoid arthritis. Once you see late findings where you will see erosion, subchondral cyst formation, subluxation, these are usually these become difficult to differentiate from rheumatoid arthritis with superimposed degenerative disease, because that is also possible. So here you can see, if you look at the joint spaces, you will see erosions. And if you look here, you will see that there are areas of periarticular osteoporosis. So keyword for rheumatoid arthritis is periarticular osteoporosis. Again, periarticular osteoporosis. Okay, juvenile chronic arthritis. Previously it was known as juvenile rheumatoid arthritis, JRA. But there are actually many different subtypes. You don't have to know that, but the appearances are basically the same as rheumatoid arthritis, only in a younger patient. There are different subtypes depending on the degree of involvement, but at your level, I'll save you the trouble, you don't have to memorize this. As long as you know that this classification exists. And then we have your seronegative arthritis. Kasi rheumatoid arthritis, that's seropositive for your rheumatoid factor. But what if you're seronegative for that factor? That's where your other arthritis like ankylosing spondylitis, psoriatic arthritis, and Reiter syndrome come in. How to differentiate between them? Ankylosing spondylitis usually involves the axial skeleton. Psoriatic arthritis involves the appendicular skeleton. Reiter syndrome involves the lower extremities. So for the easiest to differentiate is actually ankylosing spondylitis, because like I said, it involves the axial skeleton, and with ankylosing spondylitis, you have what is known as the bamboo spine. You have bamboo spine, and you have fusion of your sacroiliac joints here. So that's typical for ankylosing spondylitis. And you can easily differentiate your bamboo spine from your other spinal diseases because of the pattern. So this is an example of the bamboo spine of ankylosing spondylitis, and this one are where you have bridging ossification. That's typical for psoriasis or Reiter syndrome involving the spine. Okay, gout. Of course, with gout you have hyperuricemia. Radiologic features. Early on in the disease, you will expect to see nothing. It's supposed to be normal. But later on, you may be able to see transients of tissue swelling. But if you have chronic gout, that's where your permanent radiologic abnormalities come. So of the many different radiologic abnormalities, maybe the most common and the most characteristic are yung erosions of the bone, and where you have your punched out or rat-bitten appearance. So that's for gouty arthritis, punched out rat-bitten, that is the basically hallmark for it. Although you may be able to see calcifications involving the soft tissues or in the interosseous compartments in the hands and feet. One of the most common sites of gouty arthritis involvement is the first metatarsophalangeal joint. So this is known as podagra. So podagra. Tophaceous gout is something like this. You will see your soft tissue masses which are actually tophi in both hands. And you will see that yung underlying osseous abnormalities are more typical for erosive changes. Okay, infections, acute osteomyelitis, etc. So, like I said, you can have focal lytic changes and you can have aggressive reactions, including Codman's triangle. So that's the problem. That's the problem with osteomyelitis. And in this case, what will favor osteomyelitis over malignancy is the clinical data. I mean, sudden onset, especially for acute or for chronic, it's a history of previous infection. So here, that's a nice thing about the radiograph. You can compare the normal right with the abnormal left. You can see aggressive periosteal reactions, some degree of periosteal upliftment, and you will see that for this particular patient, there's already involvement of the epiphysis and diaphysis. Skip this. One of the things to know is yung definition of terms when we're talking about osteomyelitis, and chronic osteomyelitis in particular, is the formation of a sequestrum, the formation of an involucrum, and the formation of a cloaca. For sequestrum, we are talking about devascularization of bone with necrosis. Whereas involucrum, this is a thick sheet of periosteal new bone. So sequestrum is dead bone, involucrum is live bone. Cloaca refers to an opening in an involucrum which allows drainage of pus, usually going towards the skin surface. And then there you have your sinus tracts. Another important thing to talk about in osteomyelitis is your paravertebral abscesses. And that's usually associated with TB. That's why we have Pott's disease. Most important differential for this is malignancy. Vascular necrosis. I won't give this na lang sa exam, but as long as, unless again, I might give some questions, especially with differentiate, kasi you can have different types of vascular necrosis involving different bones. And for different ages of patients, nagiging iba yung nomenclature. So it usually involves a femoral head. In older patients, it's usually traumatic, and it will appear like this. Never mind the staging system. Sige, but just so you know that there is a staging system based on MRI. It can also manifest differently in children. So in children, we have what we call Legg-Calvé-Perthes disease. So that's usually seen in. It's also It's also a vascular necrosis, but it's atraumatic. There's no history of trauma. And there is, in the end, there will be infarction of the bone epiphysis. So your bone epiphysis is going to be deformed. And that's usually common in young boys. In slightly older boys, particularly yung obese patients, we have what we call slip capital femoral epiphysis. There is slippage of the epiphysis. So this is basically a Salter-Harris type 1 fracture. So this one is young patients around 4 years old. Ito papuntang teens. Ito infants. So usually there is a vascular necrosis from the vascular insult. And what happens is your epiphysis is small. And you will have corresponding developmental changes involving the hip. So metabolic bone disease, just a brief run through, we have osteoporosis, which is most reliably demonstrated in second metacarpal. But osteoporosis, although we can see the changes by X-ray, X-ray is not the primary modality to diagnose osteoporosis. When we diagnose osteoporosis, we use bone mineral densitometry, which is done by nuclear medicine, or CT bone mineral densitometry, which we do. But we can't do it in all institutions because of the software, because we don't have the software required. Another metabolic bone disease is hyperparathyroidism, and it's most commonly associated with increased amount of parathyroid hormone, most commonly secondary and most commonly from kidney disease. Although it can be primary from parathyroid adenomas, but it's most commonly secondary from kidney disease. So you will see and the most common, the pathognomonic finding is a periosteal bone resorption. So take note that I've been saying with regards to let's say arthritis, I've been giving the hallmarks for each particular disease. Like degenerative hallmark is narrowing, whereas for rheumatoid arthritis is periarticular osteoporosis, for your gout is your erosions, for your hyperparathyroidism it's a periosteal bone resorption. Sometimes you can see sclerotic bands at the vertebral end plates. So it's what we call the rubber jersey spine because they are similar in appearance to the jersey used in rugby. Problem with hyperparathyroidism, it can also mimic metastasis. And these are what we call brown tumors, which are cystic lesions which are often expansile and cystic in appearance. Another type of metabolic disease is osteopetrosis, wherein you have abnormally dense bones. So as compared to rubber jersey, the bands are more dense. So here we have what we call sandwich vertebrae. Okay, must know it. The next one is a must know. Scoliosis. Where I'm going to teach you how to measure your scoliosis. Scoliosis can be idiopathic. So if it's idiopathic, it can be congenital. So there is an associated anatomic abnormality, or developmental or neuromuscular. And it's yung idiopathic scoliosis, more common in the, actually 80% that's more common. Tapos it's usually, can be seen in usually adolescents and more often in females. So how do you measure How do you measure your scoliosis? So you pick your end, the first step is picking your end vertebrae. So how would you define the end vertebra? Your end vertebrae. The end vertebrae is the vertebrae where the curve begins. Okay. But when you say, where does the curve begin? That's where even radiologists get confused. So they think, you will think that the curve will begin here. But actually the curve begins at the vertebra which is most angulated. So it's going to be that one. This is more angulated than this, is more angulated than that. So this is the superior end vertebra. And this is the inferior end vertebra. Because the curve here, the angulation here is not as much as the other one. So when in doubt, just draw multiple lines. You can draw multiple lines across your vertebral end plates. And then you look which one is more angulated. And this is easy. So from here, you just get the angle. That's your Cobb's angle. But this is easy because it's a very severe curve. What if, like here, in this particular case, what if your angle will meet outside the plate? How will you be able to measure that? So if you're going to draw a line going there, and a line going there, you can get your Cobb's angle there. But if in real life you're doing that and you have an X-ray plate and your angle is already outside the plate, that's going to be difficult. So what do? You go back to basic high school geometry. Go back to basic high school geometry and you will see that for a line like this, if you draw, there is a geometric theorem which says that if you draw perpendicular lines to this line and another perpendicular line to this line, the angle formed by those two lines, this angle is equal to this angle. So that's all you're going to do. So, draw your line. Draw a 90 degree, draw one line perpendicular to that, get this angle. That's your Cobb's angle. So basically that's it. It's as simple as that. So the hard part is actually determining the end vertebrae. And how do you report it? So, T12, T11, 10, 9, 8. So there is a leftward curvature of the thoracolumbar spine with T8, 9, 10, 11, 12, 1, 2, and L2 as end vertebrae. The Cobb angle measures so and so. So ganun yung measurement mo. And you have to mention the end vertebrae because when the patient will come back to you for reevaluation after, let's say, rehab or surgery, you have to be able to use the same end plates so that you can determine whether there is progression or regression, whether your patient is getting better or not. So we have what we call the primary curve, which is the various abnormal curve, and the secondary curve. Other nomenclatures use the structural curve and the non-structural curve. So the structural curve is defined as having a curve of more than 25 degrees on side bending. So we also do side bending. just to check which one is the primary, especially in cases where you have more than one curve. So you can even have as much as 3 curves. Although commonly you will only have 2 curves. So you have a rightward curvature of the thoracic spine and a leftward curvature of the thoracolumbar spine. So that's 58 degrees. On rightward bending, it's reduced to 32 degrees. Tapos this one, you have a leftward curvature of the thoracolumbar spine. That's 32 degrees. On leftward bending, it becomes reduced to 15 degrees. So, going back to the definition, 32 is still more than 25. So the primary curve, the structural curve, is this one. It's the rightward curvature of the thoracic spine. Okay, so basically that's it for bones. I've talked about, so recap, talked about fractures. Some of these items of fractures, especially how to name fractures, these are must-knows. Not everything, I mean yung mga ibang subtypes of fractures, mga nice to know na lang yan at your level. But you have to be able to have a systematic way of looking at fractures. Tumors. You don't have to be able to identify whether it's an osteosarc, chondrosarc, osteoidostoma, osteochondroma, osteosarcoma. But at the very least, you have to be able to predict whether what you're looking at is an aggressive or a non-aggressive lesion. Arthritis, yung different types and the hallmarks of each. Tapos, for metabolic bone disease, ganun din yung mga hallmarks din. For infection, may konting definition of terms tayo for chronic osteomyelitis, immunoticum, sequestrum, cloaca. Tapos yung lastly for scoliosis, how do you measure scoliosis, how do you measure Kamp's angle? Okay. So that's it. Good luck sa exam, please.